Good afternoon, ladies and gentlemen. Many thanks for joining us today, and many thanks to Kate and Anzas for asking me to talk on this rather curly topic. When I've been preparing this talk, I've become aware that, for want of a better phrase, art imitates life, in that the writings on junctional trauma are fairly rare. Textbooks don't really have dedicated chapters, and where it is described, it's nestled amongst descriptions of extremity trauma and truncal trauma, making it hard to find. Now, in elective surgery, it's not uncommon to have to reach some fairly hard to get to regions, but usually we're able to take our time. When we arrive at the surgical target, we have time to pause, take stock, have a look around, and plan the next step. Unfortunately, we're not afforded that luxury when dealing with junctional trauma. We've battled to reach the hard to get to injury to find ourselves in a fairly hostile environment. It's unstable. There's usually a hemodynamic component spewing forth. And this is a situation we don't really want to hang around in. So junctional trauma is rare and therefore unfamiliar. It's urgent, it's difficult, and it's hazardous to the patient. And as such, it represents what I see as 6 key challenges, whilst distinct, have significant overlap. And they are one of diagnosis, one of anatomy, hemorrhage control, physiological derangement, decision-making, and surgical skills. This was a 23-year-old chap who I was involved in his care back in London. He was stabbed to the left upper arm and presented to his local hospital, where he was triaged as non-urgent and stuck in a waiting room. After an hour or two of waiting, he suddenly became unwell, tachycardic, hypotensive, and was put in the back of an ambulance and brought to our major trauma center, which luckily wasn't too far away, and he arrived in resus. When he arrived, he was white, unresponsive, more tachycardic, more hypotensive, but there was no real evidence of external bleeding, but his left hand was noted to be pale with no radial pulse. So I'll ask the audience, what would they do? Would they tube him, put in a chest drain, get some further IV access, start some blood? Maybe some further imaging would be helpful, or would we get him straight up to theatre, or maybe the angio suite, or is there a procedure in ED you'd like to do? So we did a chest X-ray. It showed a large left hemithorax whiteout, and a fast scan failed to demonstrate any pericardial fluid, but it did confirm the presence of a hemothorax. We put 2 large Foleys into the knife wound in his arm, inflated them and pulled back. And by this point, he was incredibly unwell and peri-arrest. We performed a left anterolateral thoracotomy slightly higher than the normal incision and higher than shown here, just above the nipple. And this confirmed, once we removed lots of clot from the chest, that there was still active bleeding high in the chest. Manual pressure was applied to the apex of the thorax, and the anterolateral thoracotomy was extended to a clamshell for access. This isn't the perfect view that we had, but this is what we were dealing with. We had a subclavian artery there, which we managed to get a clamp on after some rapid dissection of the pleural edge, and the thoracic arch can be seen there. So we had now proximal control, but no distal control. The patient was transferred to theatre, and we exposed the axillary artery through an infraclavicular incision. So we now had distal control, and then we exposed the subclavian artery through a supraclavicular incision, which revealed a lacerated subclavian artery, which was repaired with an interposition graft, and the patient survived. So junctional trauma can appear fairly innocuous, but it can also present in a very dramatic manner, but it often leads to a significantly unwell patient. So this case, I think, exemplifies those 6 challenges that I previously mentioned very well. There was certainly a significant delay in diagnosis. We had to cross several anatomical boundaries in order to achieve proximal control. There was certainly an acute hemorrhage component that needed to be addressed. This led to significant physiological derangement. There was some key decision making that needed to be made and needs to be made quickly. And then there were some surgical skills that were required. So I'm going to talk about junctional trauma initially from a bird's eye view. What is it and how do we classify it? What are the locations that we're referring to? And I'm going to expand on the 6 challenges that I have previously alluded to. We'll then go down to a more ground level and a more granular level and talk about a general approach to junctional hemorrhage, and then some management of specific junctional injuries. Where do endovascular techniques fit into all this? And then look to the future with some cutting edge technologies. Whilst I am going to be talking mostly about vascular injury, as this is the first priority of treatment and the acute complications thereof, with some mention of the less pressing complications of vascular injury, it's really, really important to keep at the front of your mind, not at the back of your mind, all of the associated injuries that occur with junctional trauma, orthopedic, nerve and soft tissue, and then depending on where you are in the body, aerodigestive, thoracic and abdominal injuries, retroperitoneal and perineal injuries. So what is a junctional trauma or a junctional injury? Well, there have been a few definitions. I guess the simplest and the one that I like the most is an injury to a location where extremities meet the adjacent torso. Even simpler is injury to the axilla, groin or neck, or an injury occurring or traversing the junction of anatomically distinct zones. But this description would adequately describe a thoracoabdominal injury traversing the diaphragm, and I'm not going to talk about those sort of injuries today. So junctional injury often leads to junctional hemorrhage, which has been defined as compressible hemorrhage occurring at the junction of an extremity with the torso at an anatomical location that precludes the effective use of an extremity tourniquet. Of course, you can't get a tourniquet on up above the shoulder or up above the groin. And 25% of potentially survivable military deaths are due to uncontrolled junctional hemorrhage. Now, this definition says compressible, and I would just suggest that non-compressible hemorrhage occurring at the junction of an extremity with the torso is a form of non-compressible torso hemorrhage. It's in this gray zone. And I think it's important because often these injuries are not actually that compressible due to either skeletal protection or hematoma. Non-compressible torso hemorrhage is a leading cause of preventable trauma death. It remains one of the greatest challenges in pre-hospital care. And if we can make any inroads to this, one of the greatest potentials to improve survival. And junctional vascular injuries, I feel, contribute to this, along with pelvic fractures and thoracoabdominal injuries. And even in the best, maturest trauma systems, 50% of these deaths occur pre-hospital or soon after arrival in hospital, prior to any opportunities for definitive hemorrhage control. Junctional trauma can be further classified into a type 1 injury, where surgical control can be gained without entering an adjacent body cavity, or a type 2 junctional injury, like in my example, where surgical control had to be achieved in an adjacent cavity, in that case, the thoracic cavity. Most of the evidence surrounding the management of such injuries, not unexpectedly, comes from the military experience. This large study over 2 months from Iraq shows that actually vascular injuries are relatively uncommon and junctional injuries even more so. However, in another study in the same, spanning the same period of time, junctional injury in the military setting rose 14-fold, due to the increased use of improvised explosive devices. And 17.5% of potentially preventable pre-hospital deaths resulted from these hemorrhages. So they're incredibly lethal, even despite their rarity. As expected, there isn't a great deal of evidence indicating what the incidence is in the civilian population, but it does seem rare. So what are the locations we're talking about? Well, I had a bit of trouble thinking what the best description would be of these locations, because often this is called the axilla when we talk about junctional injury, but it really includes the thoracic outlet, the shoulder, the sternoclavicular area, the base of neck, and the thorax. So I'm calling it thoracic outlet, really just to concentrate our minds that it is in that area. But axillary injuries would be included in this, obviously. And likewise, you know, we could use the phrase groin. I'm going to use the phrase inguinal, but it's a collective term for injuries around the groin, femoral triangle, perineum, but don't forget the back, buttocks, and gluteal regions. The neck's a bit easier. It's obviously where the neck joins the thorax, and we are aware of the 3 zones of the neck and where it joins. So these are the classic junctional areas that we'll be talking about today. So I'm going to expand on the 6 challenges of junctional trauma as I see them: diagnosis, anatomy, hemorrhage control, physiological derangement, decision-making, and surgical skills. So the first challenge is obviously one of diagnosis. Initial diagnosis of injuries can be very difficult. These injuries traverse anatomical regions, and there's significant potential for missed injuries. For example, in the neck, aerodigestive injuries, in the thoracic outlet, brachial plexus injuries, and then in the inguinal region, bowel injuries. And often these patients are presenting with distracting hemorrhage and life-threatening injuries, and therefore these associated injuries can be at the back of the mind. And also, for example, in our example, the bleeding was occult. The next challenge is that of anatomy. These injuries traverse anatomical regions, and these anatomical regions themselves are traversed by major neurovascular structures. Proximal and distal control is often achieved in anatomically distinct regions. So surgeons that are looking after these injuries have to be comfortable operating in these various regions, and they are often difficult to access, control, and repair. These injuries are often associated with a significant hemorrhage control component, whether that be compressible or non-compressible, and the issues of skeletal protection, adverse vessel anatomy, and depth all add to the problems. And obviously, traditional tourniquets are impossible to apply proximal to injuries in these locations. And manual pressure, if it is effective, can be difficult to maintain. Due to the significant hemorrhage, these patients often present with significant physiological derangement, and whilst we might not be able to prevent this on their presentation, we certainly have to mitigate the triad of death characterized by hypothermia, coagulopathy, and acidosis that we're all unfortunately so familiar with. Decision-making is probably the most difficult thing in this whole, in all these challenges, because you have to make the correct decision and make it quickly. So some key questions to ask are, is there a junctional vascular injury? And we can use the assessment of hard or soft signs to assess that. Is the vascular injury a cause of significant patient compromise? For example, there might be the absence of external hemorrhage in a shocked patient. And we must remember that vascular injury doesn't always present as hemorrhage, but also ischemia or both. Has an adjacent anatomical region or cavity been wounded? And how urgently does the vascular injury need treatment? Is it compressible or incompressible? Is the patient stable and we can get a bit more information about what's going on, or do they need to go immediately to theatre? And then what is the optimum strategy for treatment if they are going to theatre? Is it damage control or definitive repair? And what's the best surgical incision for proximal control of a likely injured vessel? And this is something that I'm going to stress in the talk, because I think that this is quite a confusing thing, particularly in the thoracic outlet. So these decisions can be synthesized into the 4 R's: recognize the junctional nature of an injury, resuscitate according to the C-ABC algorithm. I'll expand on this. Request appropriate help if required, particularly in this era of increasing organ-specific elective surgery. And then remember the potential for those injured non-vascular structures once you've achieved hemorrhage control. Surgical skills transgress really the conventional precincts of elective surgical specialism, as I've said. And these junctional injuries on top of that are often the most taxing to repair. They're time critical, the anatomy is challenging. And for example, the subclavian artery is a soft artery, starkly intolerant of suboptimal technique. It requires a calm and effective teamwork and communication with everyone. And therefore, whilst I talk about surgical skills and we all think about these hard skills, in fact, the so-called soft skills are just as important and perhaps even more so. So I'm going to give a general approach to junctional hemorrhage, and there is some overlap here with the general approach to vascular injury, but I'll keep it as focused on junctional hemorrhage as I can. I'm going to talk about mechanism of injury, initial assessment, physical examination and immediate treatment, and you'll notice investigations comes after immediate treatment. We then will talk about damage control techniques that we have at our disposal. Mechanism of injury is important just to have in the back of your mind. In Australia, the majority of injuries we see are blunt injuries with a little bit of penetrating, and thankfully in the civilian environment, we don't see many blast injuries at all. But it's important just to think about vascular injury in terms of what's actually happening, particularly if you're treating an injury conservatively. Small intimal tears can lead to larger flaps, which then dissect, thrombose, occlude, and result in ischemia. If you have a frank laceration, then clearly that can present as hemorrhage, but can also present as ischemia, and then the later sequelae of these injuries, such as false aneurysm or an AV fistula. Initial assessment, like any trauma assessment, according to ATLS guidelines, are following ABC. However, in the presence of catastrophic hemorrhage, we borrow from the battlefield ATLS algorithm, and we stick a C in front of the ABC. That C stands for catastrophic hemorrhage control, with the recognition that if you don't get on top of this, then actually the other things are less important from a priority point of view. Control, this is referring to compressible hemorrhage. We can apply pressure, we can pack if appropriate. Pre-hospital packing of abdominal or chest cavities is not recommended, but certainly packing junctional wounds is highly recommended. And unfortunately, we don't have tourniquets available for standard junctional trauma later in the talk, and our normal tourniquets are not useful for these injuries. In assessing vascular injuries, we need to assess the circulation in extremities. And how do we do this? Well, we assess for the hard or soft signs of vascular injury. And these are really important. And I think people jump to CTA very, very quickly. And I'm not saying that we shouldn't do that as well, but you can get so much information from a thorough examination that now enables you to predict what's going on. So what do we mean by hard or soft signs of vascular injury? I find that when we look at the textbooks, the first couple of parameters are usually the same, hemorrhage or hematoma, but then things change a bit. And the way I look at this are that there are 4 signs you need to look for: hemorrhage, hematoma, distal pulse assessment, and then a local sign, and then assess whether you're seeing a hard or a soft sign or no sign. So if you've got active pulsatile bleeding or a shocked patient, for example, in our case, then that's a hard sign of hemorrhage. If you have an expanding or pulsatile hematoma, that's a hard sign. An absent distal pulse is a hard sign. And then the local sign is a bruit or a thrill, which indicates an AVF. If they're absent, you really can reliably exclude significant vascular trauma. And if they're present, well, it really does increase the likelihood of vascular trauma, but of course not pathognomonic. If the patient's got a history of bleeding, then that's a soft sign of hemorrhage. as long as the patient's not shocked. If they have a soft or non-expanding hematoma, a reduced distal pulse, then that's a soft sign. The local sign for soft vascular injury is the injury proximal to a named artery. So example, a stabbing to the groin, that's a soft sign because you're close to a femoral artery. A femoral fracture, a soft sign because you're close to the SFA. The presence or absence of soft signs is merely indicative but useful. So a few things on junctional hemorrhage here. Penetrating injury to the subclavian artery often presents with shock. Remember, if you're assessing an inguinal junctional injury, EFAST doesn't see the retroperitoneum, and you can lose a lot of blood in that space. Pulses are quite hard, I think, to assess, often in a patient that's hypotensive, cold, and pale. And it can be hard to really determine whether you think the pulse is reduced or not. And I would just stress that you should overcall it. If you think it's reduced, it's reduced. If you think it's absent, absent. Don't put it down to spasm or the patient being cold. Call it absent or reduced, and then go from there. And assessing the pulse is really trying to assess the most proximal pulse, because distal pulses, when patients are hypotensive, is quite difficult. How does an absent pulse look like in a neck injury? Well, that can present as a neurological sequelae of stroke or loss of the superficial temporal artery pulse, obviously a branch of the external carotid artery. So why am I dwelling on this? Well, these signs really do help determine the immediate management strategies. If you've got bleeding, assess for the signs, and if there's hard signs, they really need immediate intervention, almost always with open surgery. If they've got soft signs, then you've got a bit more time for further investigations, and then you might go on to observe the patient, perform an endovascular procedure, or maybe still open surgery. So what are those further investigations? Well, in terms of assessing vascular injury, we have a whole range. So ABI, again, is really useful, but rarely done in the sort of busy, noisy trauma setting. But an ABI of greater than 0.9 really does reliably exclude a significant vascular injury. The IEI, or Injury Extremity Index, is analogous to the ABI in trauma. And another thing is just if you see a difference in blood pressure of greater than 20 millimeters of mercury between extremities, this should pique your interest. X-rays, again, not so much for junctional trauma here, but displaced femoral fractures, posterior knee dislocations, you've got to wonder about those adjacent arteries. In terms of junctional trauma, chest X-ray can be helpful here. For example, in a subclavian artery injury, that can manifest as a hemothorax. Arterial duplex is our real go-to in elective vascular practice, fantastically sensitive and specific by experienced sonographers, but not great in the acute trauma. As I said, it's very operator dependent, and timing and availability isn't really there. And in junctional trauma, often the vessels are deep and hidden by either skeletal structures, bowel, or hematoma. Now, it's important that I'm not talking here about EFAST or POCUS specifically for trauma. That's obviously very valuable. But arterial duplex is useful for screening in those less acute situations. CT angiography is now the gold standard diagnostic modality, and has replaced catheter-directed angiogram for this use, and is part of our trauma pan scan. Just one thing to bear in mind, you can get a bit caught out if you're not aware of the timings of the scans that you're looking at, and you can mistake pooled blood, for example, for active bleeding. And so an understanding of the timing of your scan is useful. Catheter-directed angiogram, as I said, has been superseded for diagnosis, and now it's almost always used in combination with therapeutic intent, knowing what we're getting ourselves in for with a prior CTA. It does have a role, for example, in unstable patients after hemorrhage control as part of non-table angiogram. So you've achieved hemorrhage control, and now you need to perform an angiogram to plan your next move. And for multi-level injuries or extensive soft tissue injuries, for example, shotgun injuries, I'm not talking about gunshot, I'm talking about shotgun injuries, which are multi-level, it's invaluable. And then it really does have a fantastic role in those very hard to get injuries up in the zone 3 of the neck, and has some role in thoracic outlet injury, which I'll talk about later. So if we have assessed our vascular injury and decided there are hard signs and they need to go for immediate intervention, then you need to decide at that point, are you going, or during the operation, at least early stages of the operation, are you going to perform definitive repair or damage control? And really this depends on a lot of factors, most importantly, the patient's physiology, the burden of injury, the local resources of where you're working, and the surgical skills. So what are the damage control techniques that we have available to us in vascular trauma? They're the use of Foley catheters, temporary shunts, knowing what to do with vein injuries, fasciotomy, arterial ligation, and amputation. So Foley catheters are invaluable in junctional zones, and as we used in our opening example. It's useful to use the big 18 French 30 ml balloons, but 10 ml balloons can be used as well. And often they're used as a temporary control prior to surgical exploration, as shown in these pictures. Sometimes you may need to put more than one balloon in if the first one isn't adequate. And sometimes if the wound is large, you may need to approximate that wound with some sutures to stop the balloon from falling out. For example, in this case, 3 balloons have been used with sutures. In this case, it's been used for definitive control, most often in venous injuries that don't require surgical exploration, and then they can be deflated a day or 2 later in a controlled environment, and if the patient's well, then potentially discharged. I think this is used more in lower resource healthcare settings, but still a really invaluable thing to have in the back of your mind. Here's a couple in some pretty nasty areas. So on the left, axillary shoulder region, and on the right, this chap's had 4 put in a supraclavicular stab wound, and you can see both these guys have got chest drains in, indicating the associated injuries that we mustn't miss. The next damage control technique is that of a temporary shunt. This maintains perfusion without subjecting the patient to a lengthy definitive repair. You can essentially use most sterile tubing at your disposal, and it's important to try and get a good size match for the artery that you're shunting. But obviously the vascular shunts shown on the bottom here are preferable because they're soft and won't damage the vessel. Argyle shunts are good. They come in a packet of 4 different sizes. So the indications for shunting are as a primary damage control technique in multiple vascular injuries. You haven't got time to fix all at once, or in a patient who's very unwell and won't tolerate definitive repair, or you're transferring that patient to definitive care for a definitive vascular repair, or you have anticipated prolonged ischemia. So for example, if complex repair is required and you're going to have to harvest vein, etc., then you might want to put a shunt in there. If it's a combined orthopedic and vascular injury, you might want to put a shunt in, allow the orthopedic surgeons to fix the femoral fracture, for example, and then you can go back and do the femoral artery repair or bypass, or if there's going to be a delay in revascularization. There are some considerations. It does commit that injury to a graft because you are having to tie the shunt in, and that will crush the intima. So you can't then repair that with a patch because you'll leave crushed intima. It's not associated with limb salvage below the knee or elbow because the vessels are small and the shunts don't flow very well, but it's great for proximal injuries. You need to be very vigilant of thrombosis and dislodgement throughout its whole time, and this can be done with handheld Doppler regularly. Keep the dwell time as short as possible, but it is surprising how long these can stay in anticoagulated and patent, and anticoagulation is often not required and often contraindicated anyway in these polytrauma patients. There are several techniques for optimal performance, and there's some tips and tricks that you need to get your head around to improve patency, ensuring adequate thrombectomy distally and proximally prior. You can snowplow soft intima in healthy vessels with the sharp edge of tubing if it's not a specifically designed vascular shunt. And if you've got a mixed arterial and venous injury, then you might want to think about shunting that venous injury and doing fasciotomies. All of these will optimize the patency of your arterial shunt. There's a couple of different configurations. In the top right is an inline shunt. This is a big shunt in an iliac injury. Big shunts flow better and they're out of the way, less likely to be pulled out. Loop shunts are used here with larger defects or unstable fractures where there's going to be a lot of movement. So, for example, here this is a femoral fracture shunted, allowing a nail to be put in prior to arterial reconstruction. Fasciotomy is really important to remember. Failure to perform adequate fasciotomies after revascularization for acute limb ischemia is one of the most common causes of preventable limb loss. And so it must be applied liberally in lower extremity trauma. It must be done, or you should strongly consider doing it before vascular repair. Otherwise, you're just leaving the leg with a compartment syndrome for a few more hours. There's not much I'm dogmatic on, but I would say that they should always be 4 compartment, they should always be 2 long incisions, and they should never be closed. Regarding venous injuries, you really only want to be repairing these if you can do it very quickly, just with a couple of sutures, and that's it. You can ligate most large veins, not the portal vein, however, that does need reconstruction. And the reason for ligating these is because actually vein repair is quite technically demanding. It takes a bit longer, and they thrombose a lot easier than arteries with poor long-term patency. So arterial ligation, this is a bit of a hardcore damage control technique, if you like, but it depends where you are. But if you're ligating external iliac, common femoral or popliteal arteries, there's a good chance of lower limb ischemia and limb loss. However, there are some arteries that there is a low risk of ischemia, for example, the upper limb arteries, because of good collateralization. And then there are some arteries that you can ligate with minimal consequences due to, again, good collateral supply, external carotid and internal iliac. And I guess in combination with arterial ligation comes amputation as a damage control technique. And this is a legitimate damage control technique when you've got devastating mangled extremity injuries that are unsalvageable, or, and I guess this is a bit harder, you've got a potentially salvageable limb, but in a physiologically very unwell patient that won't withstand it. The damage control approach to me would be arterial ligation, debriding all devitalized tissues, perhaps with a simple guillotine amputation, and then reevaluating 24 hours later and leaving as much tissue behind as you think is, as long as it's viable. Document extensively, and amputation in this setting should be a collaborative consultant-led discussion with trauma, vascular, orthopedic, and plastic surgeons. So moving on now to the management of specific junctional injuries, I'm going to talk about thoracic outlet or axillary, inguinal or groin, and then a little bit on neck, but this is really a talk in its own right. So looking at the thoracic outlet, you'll see from this diagram the most obvious thing is that brachial plexus wrapping around the subclavian and more the axillary artery. And the reason you can see this is because the clavicle's been removed. Now, whilst we will be dwelling on the arterial and venous injuries, we must remember those associated injuries, and particularly the brachial plexus here is key. This really is a primary determinant of outcome. A perfused inanimate hand is no use to anyone. And it's important, if you're going to do an open approach to the artery, then you should try very hard to identify the nerves at the time and obviously preserve them, and involve a nerve surgeon at the time, because immediate repair of sharp injuries actually does have a reasonable potential for functional gain. Traction injuries to the vessels usually is devastating due to tractional injury to the brachial plexus. Chest x-ray can be useful here. This is an apical cap shown on the left, and there's an associated scapular fracture. A hemothorax here following a stab wound to the right chest, and another hemothorax here on the left. So we've got a thoracic outlet injury. We've done our initial assessment according to C, A, B, C, D, E, and we've assessed for our vascular signs, and we've decided they've got hard signs and they need open surgery. The biggest thing I've found is there's a whole plethora of incisions for junctional trauma in the thoracic outlet, and it's very confusing. There are 8, as I've identified here, and it can be overwhelming, and you don't want to be having decision fatigue or undecided which one to use when you're facing these sick patients. So we're just going to go through all of them, and obviously that you know, there isn't a one size fits all, and you do have to think about it, but hopefully a bit of clarity will help. So the anterolateral thoracotomy is your go-to ultimate proximal control of aortic arch branch vessels as a clamshell. This is for your exsanguinating peri-arrest patient. It's a quick and simple utility incision, and particularly if extended for a clamshell, it gives you excellent visualization. And obviously you can extend it to a clamshell if you're worried about right-sided chest injuries as well as left. A high anterolateral thoracotomy, again, the indications are the same. This is performed above the nipple in the third intercostal space, and really used if you suspect a higher proximal thoracic outlet vessel injury. The view's not good at all, and you might want to extend across the chest as a clamshell, and you can actually put it lower on the other side below the nipple, but gives access to the left subclavian, as we saw. Median sternotomy, better access to the right subclavian artery, a little bit tricky to get to the left because of the posterior position of that artery. You need a relatively stable patient, and in that, I guess you can argue, what do I mean by that? And but you know, I don't think there are many places where you can do sort of crash sternotomy. If there are, you know, then it might be appropriate, but you do need some relative stability to get the patient up to theatre and do this incision. It is extensile, and you know, you can go down into the abdomen for a laparotomy or up into the neck. Trapdoor incision, so this is a combined clavicular sternotomy and anterolateral thoracotomy, gives excellent exposure, but it's highly morbid, with causalgia and brachial plexus injuries associated with it, and it doesn't really add much to using just 2 of those incisions. And you know, it's described in the textbooks, but I don't think it's really used much in practice at all. So the supraclavicular incision, this is the classic elective approach to the subclavian, but it is actually quite a technically demanding dissection, even in an elective setting. But you can combine it with an infraclavicular incision, as we did in our example. The infraclavicular incision is really access to the axillary artery only, but it's direct and simple, but doesn't give you access to the subclavian. Transclavicular incision, I'm going to dwell on a bit more. This is an excellent utility incision to access most of the subclavian and axillary artery. You go through the bed of the clavicle, and it replaces the combined supraclavicular and infraclavicular incision. Technically less demanding than the supraclavicular incision, perhaps, and the clavicle can then be replaced for lower morbidity. As in any trauma incision, you want to be thinking about extensor incisions and what happens if I find something else. So all of these incisions are extensor, either distally or proximally, and that's really important. So this is the classic supraclavicular incision. You divide clavicular head of sternocleidomastoid. There's the scalene fat pad there, which has to be mobilized. And then you see the anterior scalene muscle with a phrenic nerve over it, and you have to mobilize that phrenic nerve. And there you see the subclavian artery, the vertebral artery, internal thoracic artery. It looks nice, and it is a lovely dissection to do, but it is technically demanding. There is potential for injury to the thoracic duct on the left, and that phrenic nerve you have to be paranoid about. Doing this in the presence of a hematoma, I think, would be pretty challenging. Kenji Inaba is a trauma surgeon from LA County, and he describes he's a real proponent for the transclavicular incision, and describes it really as the only incision you need for the subclavian artery injuries. The key is to remove the clavicle. Now, I would strongly recommend that you look up this video. It's from Arizona Trauma Association when Kenji was speaking in 2015, and it's excellent. And I've borrowed some pictures from this because I've found it so useful. So these are all his pictures. They're not mine, but I just think they're great. So you can see that the clavicular incision is not parallel to the clavicle, but crosses it, and you can see the sternocleidomastoid there. You then remove all the muscle with the periosteal elevator, and this is a bit more challenging in men, a bit more muscular. You have to get around the whole clavicle, so you can't have shortcuts with that, getting the muscle off. You have to get all the way around, and then a jiggly saw as proximal as possible at the sternoclavicular joint, and then with a sharp towel clip, you can actually lever the clavicle out the way, and then it's just everything's there in front of you, and it's a really nice incision to expose all of those injuries, or all of those anatomical structures. And then Kenji describes reconstructing the clavicle mostly in women, but you can reconstruct it in men, but you can just leave it, and apparently doesn't cause too much in the way of functional loss. So I'd recommend looking that up. The infraclavicular incision, as I described earlier, is really to control the axillary artery or expose it. If there is an axillary artery injury, there's often a venous injury, and there's often a brachial plexus injury as well. This is a relatively straightforward incision. You split the fibers of pec major, and then you can retract pec minor laterally, or you can divide the tendon if you wish. Often you're looking for the artery. You've got to get through this thick clavipectoral fascia. So the artery and vein won't pop out at you until you actually cut through this thick fascia. So what are our damage control techniques in the thoracic outlet? The Foley catheter is obviously useful. Temporary shunts, yes. You can ligate veins. Fasciotomy is rarely required for subclavian and axillary arteries in the upper limb, and arterial ligation is tolerated fairly well in the upper limb due to the collateral supply. Just a word on definitive repair of the subclavian artery. It is a delicate artery and rarely amenable just to a simple repair. Usually needs a graft, and usually you can't use the GSV because of a size mismatch. So interposition graft 8 mil with externally supported ringed PTFE is usually the go-to, but you can use unsupported or Dacron graft. So moving on to the inguinal region, again, we're very mindful of the arterial and venous injuries, but remember the bladder, the rectum, the small bowel, and the colon here. So you've identified there's an inguinal junctional trauma with hard signs of vascular injury, and they need to go for open surgery. Again, you're faced with this, which incision? Well, it's actually a bit of a better scenario here. There's not as many incisions to choose from. I think your midline laparotomy would be your go-to for most surgeons. It's obviously our utility incision for an exsanguinating patient and familiar to all trauma surgeons. You still do need to dissect the posterior peritoneum though, and potentially mobilize the colon to access the external iliac artery. So there's a bit of work to do once you get into the belly. The advantage here, obviously, you can look for and treat other intra-abdominal injuries. The Rutherford-Morrison is a retroperitoneal approach, and if you're familiar with it, it's very nice, but it might take a bit longer if you're not. But it's extraperitoneal with a low morbidity. However, you obviously can't evaluate abdominal contents, and you may still need to perform a femoral exposure, but you can do this quite nicely if you just think ahead with an extensile hockey stick incision, where you've now gained proximal and distal vascular control in this region, and then can repair the vascular injury. The extended femoral is the smallest incision. It's less morbid and it's simple, so it's kind of tempting. But I would say that you could get yourself into a lot of trouble quickly if you're unable to achieve proximal control. And for unstable patients, I wouldn't recommend it. And you might need to divide or negotiate the inguinal ligament. So just be mindful about this, using this in an unstable patient, and I would use one of the other incisions for proximal control. If you do use this extended femoral incision, obviously you don't want to go into the hematoma until you've got control, and you might need to cut the inguinal ligament as shown here on the left, or you can make a split in the external oblique above the inguinal ligament and get a retractor and then clamp the external iliac as shown on the right. This is the Rutherford-Morrison retroperitoneal approach. Really nice, lovely exposure of the iliacs, but just might take a bit longer if you're not familiar with it. We have the damage control techniques available to us in the groin and inguinal region. We can use Foley catheters, temporary shunts, ligate veins with impunity. Fasciotomies need to be performed liberally with the lower limb in groin junctional traumas, and arterial ligation is not tolerated as well. If you ligate the common femoral artery, there's about a 50% chance of limb loss. So moving on to the neck, as I say, I'm not going to dwell too much on the neck. It's a lecture in its own right, but this anatomical diagram really does highlight the amount of clockwork in this region. And for that reason, we really need to bear in mind the associated injuries to the aortic arch, main branches, brachiocephalic vein, lung, larynx, pharynx, esophagus, thoracic duct, and cranial nerves. We have a patient with hard signs in the neck. We're going to go to open surgery. Which incision? Well, again, it's quite simple. There aren't as many incision choices to be made here. I guess if the patient is exsanguinating peri-arrest, then your anterolateral and extended into clamshell thoracotomy would be your utility incision for proximal control of zone 1 carotid injuries. The median sternotomy, again, needs some relative stability, if you like, but would give a good exposure of zone 1 carotid injuries and can be extended into the neck as an extensile incision. So this is your utility incision for zone 2 neck injuries, the oblique sternocleidomastoid incision. This is our elective approach. It's simple and quick, and you can extend it, as we've seen, into a sternotomy. This is also your approach for a zone 3 injury if you have to do it, but as I'll talk to in a minute, you don't really want to be up in zone 3 with open surgery unless you can help it. Damage control techniques, we can use the Foley catheter, temporary shunts. We can ligate veins with impunity. Fasciotomy is not appropriate here. Now, if you ligate the internal carotid artery as a damage control technique, especially in a hypotensive patient, there's a high chance of stroke. If you ligate the common carotid artery, there's less so because the ICA remains perfused via retrograde perfusion from the external carotid artery. So if you can keep the ICA in flow with the ECA, then that's a much better scenario than ligating the ICA. Just to bear in mind that there has been some evolution in the treatment algorithm of neck injuries. Traditionally, if the platysma was breached, that mandated exploration. Most of us now manage according to a zone of injury of a no-zone approach, which is based on physical exam and seems to be a sensible way of doing things. But for those of us that still use the zones of the neck, proximal control in zone 1 is in the chest, zone 2 in the neck, and zone 3 preferably endovascular. So I've already described the sternotomy that can be extended. The standard sternocleidomastoid approach is quite nice even in the presence of hematoma. If you stick to those landmarks and you do not go on to the next stage until you've seen that landmark, you can actually navigate your way around the hematoma quite nicely. Zone 3, best identified preoperatively, and you really want to avoid surgery and get these injuries dealt with endovascularly if possible. If they are discovered intraoperatively, if you have to be there, then you'll need to do a high carotid exposure, dividing the digastric muscles. And if you have to ligate the ICA and you can't get to it, then one trick is to put a Fogarty catheter up into the lumen, blow up the balloon, staple off or clip off the catheter, cut it and leave it there as a permanent embolization device. But there's a high chance of stroke in that scenario. So where do endovascular techniques fit into all this? Well, if you're, forgive me a further analogy, if we, as the surgeon are here and the injury's here, one approach is the direct approach, taking the most direct route and cutting through everything that stands in your way. And this is really best for the unstable patient. But as we've heard, there are some pitfalls in the way. So there is another approach, and that's the endovascular approach, slightly less direct. So what are the advantages, disadvantages, and how do they complement each other? So open surgery for these junctional injuries is best for the unstable patient. It's direct, quick, simple, durable, and cheap, and you're also able to treat other injuries in that region. One of the main advantages for the endovascular approach is the physiological stress of the procedure is minimal compared to open surgery. GAs might not be required. You're not performing further dissection and therefore avoiding extra blood loss, hypothermia. You don't have a cross-clamp reperfusion. And it can be invaluable for getting to hard to reach places and for treating false aneurysms and AV fistulas. So what's the disadvantage of open surgery? Well, it's technically challenging, as we've heard, and the additional wound can lead to further blood loss, hypothermia, and can be morbid. So why don't we do everything endovascular? Well, there are a number of considerations. It's not for the unstable patient. Due to logistics, availability, it normally takes longer to get endovascular access. It requires a lot of kit and expense and specialist skills. There's certainly questions about durability of stents in young patients and in mobile areas such as the inguinal region. And you can't treat other injuries and you can't decompress hematoma. So open surgery, endovascular approaches complement each other. But you must be aware of the pros and cons of both. So what are the endovascular techniques that we have at our disposal? Well, there are three main ones I would describe. There's temporary hemostasis, there's permanent hemostasis, and then there's definitive repair. So Reboa is a fantastic example of temporary hemostasis, resuscitive endovascular balloon occlusion of the aorta, recent resurgence in it, and recent resurgence in popularity. It's less invasive, obviously, than a thoracotomy and a cross-clamp, but its role is yet to be clearly defined, but it seems to be promising in appropriate selected patients. Permanent hemostasis uses embolization coils, gel, slurry, particles. Coils shown here are highly thrombogenic and they lead to rapid vessel thrombosis and occlusion. So you can use them for bleeding vessels where distal flow is either not essential or complemented by retrograde collateral flow. And also they're great for treating pseudoaneurysms and AV fistulas. We'll all be familiar with permanent hemostasis in the form of embolization of internal iliac arteries. I've put permanent in inverted commas because when you're using gel foam, that does get absorbed, but after hemostasis has been achieved in a day or two. So it's sort of the best of both worlds. You don't permanently occlude the vessels, but you do enough to achieve hemostasis. Definitive repair can be achieved with covered stents. balloon mounted or self-expanding, the pros and cons of each. And for example, in the thoracic region, we've heard that it can be tricky to get to. There is a role for endovascular stenting, but its durability is questionable. So stents in this scenario won't necessarily last forever, but if you've got the patient out of a tricky situation, then you can address occluded stents at a later date. This is a gunshot wound to the axillary artery. You can see the extravasation on the left, and that's been stented nicely with hemostasis achieved. Here's another gunshot wound. They've achieved temporary hemostasis with a balloon. You can see it on the left picture. There's a balloon over the rib cage. That's been accessed and introduced through the femoral artery. So that's your proximal clamp. And then there's a wire coming in through the brachial artery to try and get across the injury and rendezvous with that balloon to achieve access and then stenting. High neck wounds are treated with endovascular techniques. Here's a covered stent here, and again, a gunshot wound. And in here, an example of blunt neck trauma. Blunt cerebrovascular injury is, again, sort of becoming more identified these days, and stents can be used in this scenario. So finally, what of the future and cutting edge technology? Well, some of this stuff isn't sort of future. It's been around for a long time, but it kind of falls into a cutting edge environment. So hemostatic dressings, wound clamps, junctional tourniquet, gas insufflation, and then self-expanding foam. So hemostatic dressings are used quite commonly in the military setting. They're using packing for compressible hemorrhage control, but the bandages are impregnated with something to promote bleeding. So they can be impregnated with a factor concentrator, which sucks water out of blood. They can be mucoadhesive, or they can be impregnated with human fibrinogen. This is quite an interesting device. It looks pretty vicious. It's a clamp that seals open wounds, promoting tamponade. And in this swine model, where they've removed the femoral artery, about 3 centimeters of femoral artery, so a fatal wound, they've applied the clamp, and the graph on the right shows maintenance of physiological parameters compared to the control, which is the black line, which drops fairly quickly. There are some isolated case reports of its use in neck injuries. Junctional tourniquet. So I've spoken about the inability to use standard limb tourniquets in these regions. So there's been a development of junctional tourniquets, which are used mostly in the military setting. But it's interesting, I found this picture of a junctional tourniquet, which was given to British Army medics in 1851. And it's a modification of a hernia truss. And actually, it doesn't really look that different to the cutting edge junctional tourniquet, the Croc tourniquet that's shown below. So there are 4 FDA approved junctional tourniquets. They're all military, so they've all got an acronym. So this is the abdominal aortic junctional tourniquet, which uses a pneumatic belt and actually can be used to compress the infrarenal aorta, which strictly speaking is a non-compressible vessel from a point of view of hemorrhage. Interestingly, HEMS group from Sydney out of Westmead have used this tourniquet. Now they've only used it for traumatic cardiac arrest, and therefore they haven't actually had survivors, but they've had some pretty optimistic physiological response to it. And I reckon if it was used more liberally prior to traumatic cardiac arrest, then it might actually lead to survival. This is the Croc, the combat ready clamp, which is essentially a vice which you tighten down onto any junctional trauma. This is the junctional emergency treatment tool, which is a belt and windlass, which is used for inguinal or groin injuries. This is a SAM splint, so most of us will be familiar with the SAM pelvic binder. This has been modified with 2 pneumatic bladders for inguinal trauma, but can also be used in the axilla. Getting a little bit more left field now, people have looked at reducing blood loss by raising intra-abdominal pressure with CO2 in a pre-hospital environment, with some interesting results from animal models. And this picture shows a portable carbon dioxide insufflator. And the pressure used isn't much. And for those of you that do laparoscopic surgery will know that there is some hemostatic effect of the CO2, no clinical studies. And along the same vein, rather than using gas, these researchers are using a self-expanding foam, injecting it into the abdomen, and then it engulfs all of the organs and creates this cast around the organs to promote hemostasis, which is then removed during damage control laparotomy. If you're interested in these sort of things, I think they're pretty interesting. I'd suggest looking up this paper from the Journal of Surgical Research. So in conclusion, junctional trauma is rare, challenging and lethal. It comes in many forms and it may be occult. It represents one form of non-compressible hemorrhage. It doesn't respect anatomical boundaries, and neither should you when treating it. As a trauma surgeon, you need to be prepared to expose, control vessels, and then perform damage control. And then you can call on colleagues if required for everything else. Endovascular techniques have a well-defined role in a subset of stable patients, but you have to be mindful of their limitations. And innovative solutions are emerging, but don't throw away your scalpels just yet. Robert was first described in 1954. So when you next face a junctional injury, whilst it will still remain a hostile environment to work in, hopefully now you'll feel slightly better equipped to enter into the abyss and come out the other side with you and your patient as untraumatized as possible. Thank you very much.
Thank you very much, Joe. That was excellent. Thank you. So what I'd like to do now is welcome to the screen our panelists for this evening. We have got Kirli Ray Warren from Newcastle, Peter Subramaniam from Adelaide, and Peter Charavitis from Melbourne. So welcome, everyone. Okay. If I could just encourage people to put any questions for our panelists in the chat, and I will get through them as I'll try to bunch them into themes and groups, but we'll get through them all before 7:30. So we've got about 20 minutes to have a little bit of a discussion. I thought I might start it off. We've got a question here from Ian Civil. Hard and soft signs is a dated concept. If the patient has a hard sign and is hemodynamically okay, then they would benefit from a CT angiogram. Hemodynamically unstable patients need urgent surgery. Could Joe or the panelists comment on whether the issue is more whether the patient is stable or not, rather than whether they have traditional hard signs or not? And maybe Peter Subramaniam.
Yeah.
Oh, sorry, Joe. Yep.
I might make a comment. I think one of the things that Joe said, and Joe can confirm it, he didn't just talk about hard and soft signs. He also raised the concept of, having an index of suspicion of a potential major vascular injury in the stable patient with junctional trauma. So I think that index of suspicion is probably more important than whether there's hard or soft sign. And I guess, having the facility to rapidly image and, float a balloon if you have to control it, in an endovascular fashion, or if you need to do open surgery. I guess that's more a facility issue, but I'd be interested. I thought Joe had answered that, but, Joe can tell us.
Yeah, and I think Ian's point is very good, and perhaps I didn't stress enough the stability, instability element of it. One of the the hard signs is shock, and one of the soft signs is a history of bleeding, but not in a shocked patient. So no, I think it's a very valid comment, and obviously you put all of these things together and have to synthesize them quickly. But you know, our patient that I described at the beginning, you know, didn't have any obvious hard signs to the hospital he presented to. Yeah, you know, he became incredibly unstable. So yeah, you have to put all these things together.
Excellent. So I guess well, I've got a question that leads on a little bit from that then too, is it's the angio without the CT roadmap. So as a non-vascular surgeon, I'm interested in how best to keep the patients alive and in as good as condition for you guys to do your work. One of the things we're all often faced with is we get that moment of stability to get them into the CT scanner. A lot of us are lucky enough to work in environments that have access to a hybrid suite or some form of angiography, at least in theatre, on the table. I'm just wondering if any of the panellists could comment on the absolute necessity for a CT as a roadmap for your subsequent angiography, or is it something that, you know, as vascular surgeons, you're happy to do without if the patient really isn't well enough for a CT scan? Maybe Peter Charambidis, I'll start with you.
Yeah, I'll probably continue on from the previous question and lead into this one as well. I think a significant component in many of these cases is also under resuscitation. So, and I think Joe covered it really nicely by putting the C in front of the ABC in this subgroup of people. And sometimes, or not infrequently, they are under resuscitated, and sometimes by instigating those measures, obviously not in the example he gave where the patient had a chest hemothorax full of blood, but in some of these junctional cases you can buy some time. Now, what are you going to do with that time when they've been adequately resuscitated? Do you, as you say, you know, get to the CT scanner to get a pan scan, which is not an uncommon phenomenon these days, especially in trauma hospitals, or do you use that window in order to try and get some proximal control angiographically? And that's where I think it really boils down to what your hospital's facilities are. If you're doing this in the emergency department, which doesn't have an angiographic option, and that's very much dependent on the sort of the setup that you have, such as the the tables that the patients are on, whether you have ceiling or wall or floor mounted angiographic facilities, or even a portable II. But there's a whole host of things that determine whether you can do something in the emergency department where you are, which is very reasonable if you have a high suspicion of it and you can get very quick angiographic control with just a balloon at this point in time, or whether you really need to get them to the CT or theatre first. Ideally, we all like to have the CT. It's obviously handy to have a guide as to what you are dealing with and where you are doing it. But I think there's very much it's a horses for courses type of situation where sometimes you may allow the CT to be done first, but sometimes you have to go to the theatre. There's nothing worse than having that window of stability and then finding out that the patient's gone to the CT or radiology department and that's where they've crashed. That's a devastating situation.
Excellent.
So I would argue in most trauma centres, the ideal circumstance would be to have a true hybrid situation.
Excellent. You still need to make a decision what you're going to do first, though, I guess, don't you?
Yeah, absolutely, absolutely. And that's where I think it really does depend on who you have, in your team, the degree of stability once the patient's been resuscitated, and whether you have the facilities or the options of getting angiographic control, or whether you do need to go to theatre. I've got to say, it was a great example of opening up a patient's chest and salvaging that situation that we had with the presentation. But I think for a lot of people's experience, when you're doing a trauma thoracotomy in the emergency department, the mortality rate of that is pretty high.
I guess that leads on nicely to a question from the audience too, still in relation to the case you presented, Joe. I think you can see the question there up on your screen. I'll read it out to the rest of the audience though. Following on from the previous questions, how would the panel have worked up the patient from Joe's case presentation if you'd got your hands on him before he became unstable? Maybe Kiralee, I'll start with you. If this patient had presented at Newcastle at John Hunter, but not hemodynamic hemodynamically in extremis, what would your preferred approach be?
I think this comes back to that index of suspicion, doesn't it? You know, that laceration is in a suspicious spot, but he's hemodynamically stable at the start. I think probably the most useful investigation would have been an early chest X-ray. And I think that goes back to your trauma principles. You've got to get a primary survey done early, even when the department's busy, even when you're still offloading in the ambulance bay. You know, the opportunity to get that guy more, you know, escalated level of care was with trying to diagnose that injury by index of suspicion alone, because he didn't have the hard signs. And I think, you know, that early chest X-ray potentially would have shown you quite a large pneumothorax, and then escalated his level of care, his level of resuscitation, which may have brought you that period of stability to get more definitive imaging if you're not sure. He's obviously also a penetrating trauma, so you're unlikely to have, you know, blunt missed injuries elsewhere in this patient. If he's becoming hemodynamically unstable, it's most likely related to the whole. So you've got an area of injury to focus on, which makes it more easy. I think the challenging ones are the multi-traumas that are unstable and you're not sure why. That's sometimes the harder ones to pick without more definitive imaging.
I guess another following question then is, having done the chest X-ray and you see that there's a massive hemothorax, does a CT scan in this case add anything of additional value? And maybe I'll flick it back to you, Joe. If you'd had that chest X-ray, would you have proceeded then to maybe it's a little bit hard in retrospect, but would you have proceeded to a CT scan, or would that have been enough for you to proceed to theatre?
Yeah, it's difficult. I mean, I was just thinking about a case that I approached from an endovascular point of view as a blunt trauma with a nasty shoulder fracture, and he presented with a big hematoma a bit after his original injury. So there was a call from the orthopedic doctors once he'd been up on the ward for a bit, and actually in him, whilst he had, you know, a hematoma, he was stable. I approached the whole thing endovascularly. I didn't really have the appetite to go into this hematoma and try and explore the vessel. They had an axillary artery injury, and I stented it. The stent occluded, you know, some time down the way, and then he ended up having to have a bypass. So, you know, the endovascular options are there. They can get you out of trouble, but they may be temporary. But sometimes that's not a problem. You know, an occluded axillary stent doesn't often lead to frank ischemia. And then you can, you know, treat the patient in a staged manner. And I'm not saying that was the right option. Maybe I should have gone for an open repair, you know, at that point in time. So yeah, no. So for that guy, I would have got a CTA definitely if he was stable, and to know, you know, what we were dealing with.
And just go for it. Yeah, go for Peter.
Ask Joe again if. Again, taking that circumstance back again, the case that you presented, not the one you just described, but if you had that X-ray that showed the chest was full of blood, but you had, again, a stable patient at this point in time, so you had the patient resuscitated and the chest had filled up enough to sort of create a tamponading effect that gave you an opportunity. Again, with that stable patient on this occasion, or stable-ish, let's say, and the chest full of blood, again, would you do the thoraco, or would you consider a hybrid approach? Yeah,
so I wouldn't have done an ED thoracotomy unless he was in extremis. There's always the kind of reluctance to put a chest drain in because you want to keep the tamponade effect, but I don't think that logically plays out, to be honest, because you've got to get that blood out at some point. Yeah. So you know, you can then think about putting a chest drain in, but maybe you want to move that patient to theatre to do that. You know, I think we're very reluctant to move patients to theatre unless we're, you know, knowing exactly what we're going to do, and sometimes that is the safest place for the patient. And maybe putting a chest drain in and then seeing if he became unstable, and if he didn't, then proceeding to CTA and then proceeding to an endovascular approach might be appropriate. You know, I don't think these injuries are that easy to deal with open, and I think You know, but I think in the unstable patient, and it's coming back to what Ian said, you know, they do need open surgery and they need it very, very quickly. But comes back to your point of the resuscitation. You know, what is unstable? You know, if you resuscitate them and then they respond, then you've then got a relatively stable situation, and maybe your treatment options are you know, you've got more than one treatment option.
All I would add, if I possibly can, is without using the word REBOA, because I think it's a very specific thing and it's got issues associated with its use that people are looking into and trying to improve, granted. But using a balloon for proximal control is actually usually a very quick and useful technique to get you the, you know, what your proximal control clamp would otherwise do for you, but in a more in a simpler format, without you having to work through either the different cavities or through the hematoma, which you've pointed out on a number of occasions is so true, that, you know, you could have done an operation on a particular area, you know, many times, but once you encounter that same surgery in the traumatic setting with the disruption of the hematoma, it changes the game completely. So I would say, while your presentation focused on a lot of the definitive options of endovascular, having proximal balloon control of the vessel that you're trying to deal with, that temporary as the case may be, but it's saving you from having to deal with the proximal control, is a really, really handy technique.
Yeah, absolutely. In one of those axillary artery injuries, which weren't mine, the second gunshot wounds, they put in a standard angioplasty balloon from the groin for proximal control. Another method, if you need it, although it's, you know, maybe a little bit hairy, is if you are encountering a laceration in an open environment, is to put a balloon in through that laceration and achieving balloon occlusion endovascularly, but in an open operation is another option as well.
Excellent.
I guess going back to Joe's case, you know, Joe, if the chest X-ray showed you a whiteout in a stable patient, and you had the facility to do a CT and float a wire either from the groin or brachial artery under vision, that would have prevented you or minimized the need for you to do an open thoracotomy. Yeah,
absolutely. The thoracotomy was merely as a resuscitive procedure and was not a therapeutic procedure. There was no access to the subclavian injury whatsoever. And therefore, if you could avoid doing that, it will be immensely beneficial to the patient.
So it's a bit facility dependent as well. I guess doing it in theater with with an angio facility is far better than trying to do it in an ED. And that goes to the issue regarding REBOA, I guess. You mentioned in your talk that, you know, the role of REBOA hasn't really been established. But what are the circumstances, if you don't mind me asking, through Kate, that you think that there is a use for REBOA in trauma?
Sorry, was that
do you want to answer that, Joe?
Oh, well, so
do you want to go first? You go first.
There are some, you know, fairly robust guidelines and chest. Obviously, you know, it's a proximal control balloon, so chest injury or an injury such as a subclavian, it would be contraindicated because you'd be having to park your balloon up in the arch. So it's really for intra-abdominal injury, and so I guess the role of REBOA for junctional trauma is really pelvic injury or inguinal injury. And I think there, you know, in the right patient selection, it definitely has got a fantastic role. But not currently in the chest or in these axillary injuries. But as Peter mentioned, you know, that bringing a balloon up from the groin, you know, in not a REBOA sort of scenario is a really good way of getting proximal control.
Well, as we're getting towards 7:30, I just do want to get one question in that's come up on the chat as well, and particularly while we've got the the chair of the training board here, as well as Kirili Ray, who's been through the training program maybe a bit more recently than most of the rest of us here. And that's about training with so much vascular surgery now being endovascular. And general surgeons, a lot of general surgical trainees don't even get to do a vascular term. Hopefully most do, but not all do anymore. How do we train surgeons? And I guess specifically vascular surgeons, how are you guys going about training so that even though they're not that common, you're the ones that are going to be called upon to help or to treat these patients? So maybe, Kirili, I can ask you to reflect on your training and what prepared you for it, or what do you think may need to be added to vascular training to prepare surgeons, if you need something additional, that is.
Tough question in front of people who trained me, Kate.
Sorry,
but,
I put you on the spot.
I think vascular training covers the groin junctional area as well, because we're quite used to the common femoral, the external iliac exposures. And, you know, with a steady stream of iatrogenic trauma to that area, which does give you practice in some ways. I think the thoracic outlet is harder because it's a much rarer exposure in the first place. And we are less familiar with opening the chest than we are with opening the belly. I think most vascular surgeons are quite happy with, you know, the midline laparotomy and clamps up to the superceliac, even though the endo world is getting more and more common. But I think the chest exposure is probably the bit that is most lacking in vascular training, you know, the thoracotomies, the trapdoors. But I guess that would be true for pretty much every branch of surgery outside of cardiothoracics. And I don't actually know the answer of how we get better exposure to that. I don't know.
Maybe I could throw it to the two Peters.
Yeah, I agree with Kirili. I think she's spot on. From most of the diaphragm down, and I think carotids, our training still has quite a lot of open surgery. Again, it depends on where people have trained. It's a 5-year program. We encourage people to spend time at some are endovascular heavy years, some are open heavy years, and we've got a significant number of rotations that have a mixture of both. I think that's why I think in terms of getting proximal control, the use of the balloons, our endovascular balloons, I saw one of the questions before. Yes, I'm referring to endovascular balloons, can actually do what a lot of the difficulties can sometimes be, which is getting that proximal control, because it's taking you into a cavity or an area you're not familiar with. And then using basic principles, as Joe talked about, in terms of, say ligation and reanastomosis, or patching, or a bypass, and elements like that, which people are a little bit more comfortable with. But the area that most people, I agree with Kirili, still have difficulty is the intrathoracic arch, very proximal, thoracic outlet sort of area. And I think that's where, I think if you're going to work in a trauma hospital, it's important to have exposed yourself to those areas, those skills. And if you haven't had that, again, to be able to potentially do these temporizing measures that Joe talked about, such as maybe getting a shunt in that, allows people to get to a definitive location, or even ligating the vessels, and again, then transferring to a facility where people can intervene. But yeah, that area, I think, in the chest and the arch and its proximal branches is still a very scary zone for, I think, a lot of people, both in general surgery and vascular surgery, based on where they've trained.
And Peter Subramaniam, do you want to add to that?
I think there was a good question that was asked about, and it sort of relates to it. I think it was from James Crichton. Thank you for your question. I think the specific thing you asked was, who should manage junctional trauma in this age of organ-specific specialty surgery? And I think you've heard, from both Kirili and Peter, that trauma isn't, even vascular trauma isn't primarily managed by vascular surgeons. We approach trauma as a team approach. I might say, look, I'd like to get a balloon floated through to the, from the femoral artery floated through, in an angio suite, etc. I might want my cardiothoracic surgeon to be on hand to help me if I have to open a chest. So I think the concept that vascular trauma, junctional trauma, is purely managed by vascular surgeons is not true. We don't have the volume of trauma to, even if we worked in the Alfred or other major trauma centers, we don't see a gunshot wound a day. We don't open a chest a day. Royal Adelaide, I think Joe can tell us, but I suspect we probably wouldn't open a chest more than 2 or 3 times a year. So I think the answer is a very good question. And I think the way we approach trauma is to, as we've heard today, there are principles of managing trauma. And it is not really a subspecialty sort of thing. It's really trying to leverage on the experience of other specialties and working together. And in major trauma centers, we work together. I mean, there's a cardiothoracic surgeon there. Why wouldn't you ask him to help you open a chest? Well, I would. Yeah. And I'm an old guy.
And us trauma surgeons are happy to teach the vascular surgeons how to open a chest. Many parts of Australia and New Zealand, they teach non-surgeons, but that's a whole nother night. That's another discussion. It is 7:31, so I am going to bring it to a close. I will just acknowledge some of the comments too from our Pacific Island audience who are listening in and watching in this evening, who have brought up the very important point of skills training and maintaining skills for the other people in our region, particularly given at the moment that we can't travel, and actually getting hands-on skills can be quite difficult. And is there a role for various organisations such as ANZUS to maybe look to put some more skills training? And there's been a specific question about vascular exposure and control up there. So we're hearing you, and we will absolutely take that on board. And I think really that's what ANZUS is about, is trying to get this going and have a group of surgeons who are keen to teach each other, not just obviously in Australia, New Zealand, but across our region. So thank you very much, guys, for your time and your expertise this evening. That was a great discussion. For everybody online, thank you for your attendance. You will be emailed a link to a very brief survey monkey just to get a little bit of feedback from you. Apologies if you've done it after our previous Grand Rounds, but we do send them out after each one. Let us know what you like, let us know what you don't like, and any other topics that you'd like to see presented. In 2 months' time, on the 3rd of August, our next Grand Round is actually going to be delivered by quite a unique individual. James McKay is not only a trauma surgeon, but also an intensivist. So he's done the intensive care training, and he's based in Christchurch, and he's going to talk about damage control resuscitation from the ER all the way through to the OR. So that should be resuscitation from a surgeon's point of view, but with an intensive care background. So thanks again very much, everyone, and have a good evening. Bye.